Hi, my name is Kate Goodrich, and I am the Acting Director of the Quality Measurement and Health Assessment Group here at the Center for Medicare and Medicaid Services. I'm glad to be speaking with you today about CMS policies on quality measurement and radiation safety. Our objectives for the talk today are to give you an overview of the CMS vision and scope of work, to discuss CMS quality measurement programs and vision, to review the physician quality reporting programs and radiologist participation in those programs, and finally, a brief overview of the advanced diagnostic imaging accreditation requirements. CMS has quite a large size and scope of its work. We are the largest purchaser of healthcare in the world. Combined, Medicare and Medicaid pay approximately 1/3 of the national health expenditures. This amounts to be almost $1 trillion. CMS programs currently provide health care coverage to roughly 105 million beneficiaries in Medicare, Medicaid, and the Children's Health Insurance Program, which comes to about 1 in 3 Americans. The Medicare program alone pays out over $1.5 billion in benefit payments per day and answers about 75 million inquiries annually. And millions of consumers will receive health care coverage through the new health insurance programs, the marketplaces, authorized in the Affordable Care Act. CMS has 3 aims to achieve better health care in the country. First is better care for individuals. Second is better health for the population. Third is lower cost through improvement. And this is really our guiding star for all of the work that we do. The Center for Clinical Standards and Quality is the center that I work in at CMS. We have multiple levers to improve safety, quality, and value. We have over 400 FTEs, a budget of about $1.5 billion, and about 10,000 contractors who are focused on improving quality across the nation. This includes the quality improvement organizations who are really focused on contemporary quality improvement within facilities, but also at the individual practitioner level. We have multiple quality measurement and public reporting programs that have been authorized under various laws, such as the Hospital Inpatient Quality Reporting Program and the PQRS program, the Physician Quality Reporting System, which I'll be talking about more later. We implement a number of incentives, financial and otherwise, for example, through the Hospital Value-Based Purchasing Program. We have a number of regulations. I'll be talking about some of those later on, including identifying the conditions of participation for hospitals and other provider types. And that is really tightly coupled with our survey and certification program to assure that those facilities are adhering to the conditions of participation. And finally, our group makes coverage decisions using such tools as coverage with evidence development and coverage for preventive services. My group, the Quality Measurement and Health Assessment Group, has 5 divisions currently. They are divided into ambulatory care, the hospital setting, post-acute care settings. We have a health IT division, as well as a cross-cutting program management and support. We have about 70 staff. We are responsible for implementing 9 of Medicare fee-for-service reporting programs, and we support 17 other programs across the entire agency. And we are very focused on partnering with external stakeholders in order to align measures across the public and private sector. This is an area we've been working very hard on over the last couple of years, and you may have already noticed that we're starting to align our measures across our programs within CMS. And as I stated, we are working with multiple stakeholders to try to also align with private payers. Finally, we provide measurement support to the Innovation Center, to the healthcare marketplaces or exchanges, to Medicaid, and to many other groups. The National Quality Strategy was required by the Affordable Care Act, and the first version of this strategy was released in 2011. This strategy is supposed to improve the delivery of healthcare services, patient health outcomes, and population health, and must concurrently pursue 3 aims. You've seen these before in the talk already: better care, better health for communities and for populations, and finally, affordable care. Not only that, the strategy focuses on 6 priorities. Number 1, making care safer by reducing harm, ensuring that every patient and their families or caregivers are engaged as partners in their care, promoting better communication between providers and patients and between team members of a healthcare team, and also better coordination of care, promoting the most effective prevention and treatment practices for the leading causes of mortality, and we started with a focus on cardiovascular disease. Also working with communities to promote wide use of best practices to enable healthy living. And finally, making quality care more affordable for all who are involved in the healthcare system. I'm going to start by talking about quality measurement, which is near and dear to my heart. This slide shows you the quality measurement or quality reporting programs that we have within the agency. Our group does not oversee all of these programs, but by looking here, you can see that we have a large number of programs, many of which were newly authorized by the Affordable Care Act. Of the ones that were existing before the Affordable Care Act, the Act expanded the scope of those programs and also started the shift from paying for volume of care to paying for the quality of care, or value-based purchasing, which I'll talk about momentarily. The CMS framework for measurement really maps directly to those 6 national quality strategy priorities that I just mentioned. So we have identified 6 domains under which each of our measures fall. An individual measure may cross more than one domain, but they are essentially clinical quality of care measures. In this bucket, these measures are probably the ones that you're the most familiar with. The majority of our measures right now do fall into this bucket of measures. Care coordination, population and community health, person and caregiver-centered experience and outcomes, patient-reported outcomes, safety, and then efficiency and cost reduction. And I would put appropriateness of care within that category as well. With all of these buckets, measures should be patient-centered and outcome-oriented whenever possible to truly drive improvement in care. Also, we think that the measure concepts in each of these 6 domains are common across providers and settings, and they can form a core set of measures. The high-level CMS vision for quality measurement is seen here. First of all, we want to align our measures with the national quality strategy in the 6 domains that I just mentioned. Second, it is really critical that we implement measures that fill the gaps across the 6 domains. And of the 6 that I showed before, it may have occurred to you already that there are tremendous gaps across those 6 domains, particularly in the ones that are not clinical processes of care. We have major gaps in care coordination, cost, appropriateness, patient experience, and especially patient-reported outcomes. We are working very hard, both at CMS as well as other agencies at HHS, to fill those gaps. And many in the private sector are also developing measures to fill those gaps. We are very focused, as I said before, on aligning measures across CMS programs whenever possible and where it makes sense to do so. We are looking to have parsimonious sets of measures and core sets of measures across all of our programs. We have certainly heard from the provider community that we have quite a few measures. Some people think we have too many measures. I will say that for most programs, we think that we are already starting to reduce the number of measures that we have. However, some programs really require a larger breadth of measures, such as the PQRS program, in order to ensure that we have measures available for all the different specialists out there. We also have been removing measures from our programs that we think are no longer appropriate because either they are topped out, so the performance is so high across the country on those measures that it no longer shows differences in quality across providers, or where the evidence base has changed, and so we need to remove those measures and replace them with a more updated measure. We are working with the National Quality Forum as well as private payers and states to align measures as well. We also are working with the medical boards and specialty societies to include measures that are relevant to those providers and the patients they care for, and to see if we can get to a strategy of really reporting once, where providers can report measures that meet multiple purposes, the CMS quality reporting or pay-for-performance programs, as well as for other purposes outside of the federal government. And finally, our major aim for measurement is to improve quality of care for patients over time. Next, I want to talk about a very related topic, which is value-based purchasing. And this is our purpose statement for value-based purchasing. We see it as a tool that allows us to link the national quality strategy with fee-for-service payments on a national scale. This is really a game changer in how we pay for services in this country. And with value-based purchasing, we are moving to rewarding providers and healthcare systems that deliver better outcomes at lower cost to the beneficiaries and communities that they serve. So this is really a sea change in our measurement programs and how we're paying for care. And the Affordable Care Act really started the process to move our quality reporting programs towards pay-for-performance type programs. So I've already stated the goal for value-based purchasing. There are 5 principles that we really try to adhere to as we design our value-based purchasing programs. First of all, we want to define the end goal and not the process for achieving it. And what I mean by that is the types of measures that are most critical for a value-based purchasing construct are outcome measures. We want to define where we want to be with patient outcomes. So, for example, reducing mortality, reducing hospital-acquired infections. Measures of those types of outcomes are the best types of measures for a value-based purchasing program, we think, rather than the measures of processes to achieve those outcomes. We know that local providers can innovate on what those processes might be, and we want to allow them to do that by really focusing on the end goal. All providers' incentives must be aligned. This means including providers across settings, so hospital and post-acute care settings, hospital and physician incentives. We think that over time we need to get to a place where those incentives are really fully aligned so that we're all focusing and driving on the same end goals. Finally, the right measure must be developed and implemented in a rapid cycle. Measure development timelines right now are really too long, so we're working very hard with many of our federal partners as well as with external stakeholders to accelerate our measure development timeline. CMS must actively support quality improvement. And what I mean here is if we're going to be requiring or basing payment rather on how providers perform in taking care of patients, we also think it's important to provide providers with the assistance that they need in order to be able to improve. So for example, with the Hospital Value-Based Purchasing Program, not only do we have financial incentives tied to that program, but through the Partnership for Patients program and the hospital engagement networks, we are across the country providing technical assistance to hospitals to be able to actually improve on the outcomes that they're being paid off of. And finally, clinical community, meaning providers like you, and patients must be actively engaged in these programs. These programs will not succeed, and by success we mean improved quality of care for patients. It will not succeed without the sincere engagement of providers, whether it be physicians, nurses, hospitals, post-acute care settings, and especially health systems. They must be at the table as we design these programs and implement them. A quick overview of our physician programs. Many of you are probably familiar with the Physician Quality Reporting System, the PQRS system, and a new program authorized by the Affordable Care Act, the Physician Value Modifier. Just a quick overview of the payment implications for each of these programs. As many of you know, there's been an incentive associated with the PQRS program since its inception in 2007. That incentive, by law, ends in 2014. Instead, it is being replaced by what's called a payment adjustment, and this is really just a downward payment adjustment. That starts this year in 2013 and overlaps with the incentive for 2 years. What this means is for providers who do not participate in the PQRS program starting in reporting year 2013, that their payments will be reduced just for not reporting measures. The Physician Value Modifier, the first reporting year is 2013. And just to be clear, this program is really paying providers for their performance on quality and cost metrics. So the first year of reporting is now, 2013, which affects providers' payment or reimbursement in 2015. The law says that starting with 2015 payment year, that a subset of providers can be included, and I'll talk about that in a minute. But by 2017, all eligible providers must be included in the Value Modifier program. There are a number of ways that physicians can report measures to CMS. Number one, by claims, and many of you may know these as the G-code claims, where a G-code has to be appended to the claim to show the quality action that was taken by the provider. Number two, you can report measures through a registry. So many of you, there are probably radiology registries out there that you can report through. Number three is the group reporting option web interface. This is a mechanism that is used by the ACOs who participate in the Medicare Shared Savings Program, as well as by large group practices. Now, providers can report through an electronic health record system. This is our newest reporting method. And finally, we can assign quality to providers based upon their administrative claims. So this is work that's all done by CMS. It's absolutely no burden to providers. And this is an option that currently is available to providers in order to avoid the negative payment adjustment of PQRS and for the value-based modifier if you so choose, or if your group chooses. Let me talk a little bit about radiologist participation in PQRS. So currently, the PQRS program has a number of measures applicable to radiologists, and these cross a number of the National Quality Strategy domains. They include safety, care coordination, clinical process, and appropriateness. I won't read them all out here, but you can see them on the slide. And radiologists are primarily participating through the claims, meaning the G-code claims, and the registry methods currently. Radiologists have some of the highest participation rates in PQRS, I'm glad to say. So in 2010, about 40% of eligible radiologists participated in PQRS. And in 2011, 47% of eligible radiologists participated in PQRS. And in 2011, we know that radiologists across the country earned $20.5 million in PQRS incentive payments. We won't have information about the payment adjustments until 2015 or 2016. Let me go back to the value-based modifier to give you a little bit more information there. I'm sure it's a topic that you're all very interested in. So the Affordable Care Act requires that Medicare phase in a value-based payment modifier that would apply to just Medicare fee-for-service payments starting in 2015. The phase-in has to be complete by 2017, as I mentioned before, so all eligible providers must participate by reporting year 2015, which corresponds to payment year 2017. The value modifier assesses both the quality of care furnished and the cost of that care. I will say this is an incredibly challenging and complex program. We have certainly heard from many stakeholders that they also find it challenging. It has been interesting to put together a program that we think can really start to drive improvement in the care of patients, and yet also ease physicians into a new payment construct and be fair to physicians and other eligible professionals. The law says that the program must be budget neutral. In last year's physician fee schedule rule, we finalized applying the modifier to physician payment in all groups of physicians of 100 or more. That's starting again in payment year 2015, so for the current reporting year. These proposals encourage physician measurement and alignment with the PQRS program, and they offer a choice of quality measures and reporting mechanisms. And the program also focuses just on outliers in the first year, so the very high performers and the very low performers. The value-based payment modifier and PQRS are perfectly aligned, and so that the measures that we have in PQRS are the measures that will be used to calculate the value modifier. Again, group practices of 100 or more are eligible in 2013. A group practice of 100 or more may avoid the 2015 downward payment adjustment just by self-nominating for the PQRS program as a group and reporting at least one measure. And by the way, a group practice is defined as a single taxpayer identification number. It is important to know that if you're part of an ACO, the value modifier does not apply to your group. In order for this program to succeed, again, as I mentioned before, having physician and other clinician engagement is absolutely essential to the success of this program and improvement efforts. We have multiple quality measurement efforts. Currently, I think in the last PQRS experience report, which just came out, in 2011, about 30% of eligible professionals participated in PQRS. Our goal for this year is to get that up to at least 50%. There are a number of other measurement and related quality improvement efforts going on that we hope to align with the value modifier, and that includes multiple board maintenance of certification as well as specialty society measurement efforts. So we are working with those societies and those boards to identify a way that we could really perfectly align the reporting that any given physician does for CMS to perfectly align with their maintenance of certification or with their specialty society, or if they're participating in a regional quality collaborative, so that a physician who reports to any of those programs also receives credit for PQRS. This is a work in progress. You'll be reading more about it in our upcoming rule that'll be coming out later this year. So registries are the fastest growing method by which physicians are reporting quality measures to PQRS. Many of these registries are led by physician specialty societies. There's a lot of advantages to these registries, including the fact that they include all payer data, so not just data on Medicare beneficiaries. They often have a very robust set of measures that have been developed by specialists, so they really are measures that make a lot of sense to specialists and represent their scope of practice. The success rates for reporting via registries are very high, higher than through the G-code claim option. We also have, again, authorized under the Affordable Care Act, an incentive related to the maintenance of certification. So your board may be letting us know when you have participated in, I think it's the Part 4 of the maintenance of certification, and you get an extra incentive through the PQRS program when you do that. There is increasing bidirectional communication and engagement between CMS and the boards and specialty societies. We meet on a regular basis with the specialty societies, and we'll meet with any who want to meet with us, because we truly believe that these will not succeed without your engagement and the board's engagement and the specialty societies. And finally, as I mentioned before, there's a lot of work to align our measures with the specialty societies and with other payers. Finally, I'm going to talk a little bit about advanced diagnostic imaging. The requirements for this came from the Medicare Improvement for Patients and Providers Act from 2008, affectionately known as MIPA. And this act required that the Secretary designate organizations to accredit suppliers and who furnish the technical component of advanced diagnostic imaging services, or ADI. The procedures that were defined as ADI include MRI, CT, and nuclear medicine imaging such as PET scans. It expressly excluded X-rays, ultrasound, and fluoroscopy procedures. The suppliers of imaging services may include physicians, non-physician practitioners, and then independent diagnostic testing facilities. So, who does this affect? Well, I'll first tell you that this applies only to the suppliers of the images themselves, so it does not apply to the physician's interpretation of that image. That's a very important distinction. An ADI that is furnished in a hospital inpatient or a hospital outpatient setting, this does not apply. And the accreditation requirement applies only to those suppliers of ADI that are paid under the physician fee schedule. So what do the quality standards address? A number of things. Qualifications of medical personnel who are not physicians, qualifications and responsibilities of the medical directors and the supervising physicians, procedures to ensure that the equipment used meets performance standards, procedures to ensure the safety of the people who are furnishing the image, as well as to ensure the safety of the beneficiaries themselves. And finally, establishment and maintenance of a quality assurance and quality control program. There are 3 accreditation organizations currently. They include the American College of Radiology, the Intersocietal Accreditation Commission, and finally the Joint Commission. I want to reiterate, the accreditation requirement does not apply to radiologists per se. However, the interpreting physicians must meet the accrediting organization's published standards for training and residency. And finally, each accrediting organization has its own standards. So it's been a pleasure talking to you today. I think I'm going to be available to answer any questions for you. And here's my contact information. We do respond to all inquiries, all letters, all phone calls, so please feel free to contact me if you have any questions after this talk. Thank you.